Yeah, good day. I have the pleasure to co-moderate this with Dr. Kim.
Yes.
And without further ado, I would like to introduce the first speaker, Dr. Ahmed Adel Shaheen, who is going to present his interesting case on horrible STEMI in COVID-19 era.
Hello, everybody. I would like to thank everyone who gave me opportunity to present this case in such prestigious meeting. Without further ado, I am going to present my case. Do you hear me well?
Okay.
Yes.
Okay. This is horrible STEMI in COVID-19. I have nothing to disclose. This is 75 years old, male, type 2 diabetes, hypertensive, heavy smoker, dyslipidemic, presented with typical chest pain associated with sweating and excessive vomiting for 3 hours. Patient was transferred to a district hospital where there is no PCI available. In emergencies, patient crashed and his blood pressure became unrecorded, promptly transferring to our ICU, actually 6 hours post chest pain. Vasopressor was given at maximum dose, but patient was still, blood pressure was unrecorded, however. Patient then has been intubated and kept on mechanical ventilation. His ECG showed ST elevation 1 AVL V2 to V6 with right bundle branch block. And bedside echo showed severe anterior anterolateral apical and anteroapical hypokinesia with ejection fraction 10 to 15%. Patient then arrested in VF. Cardiopulmonary resuscitation was started promptly, and thankfully restoration of circulation after 4 cycles. Then ICU team activated cath lab around 3 a.m. So our summary is this old patient with multiple risk factors presented relatively late in a cardiogenic shock post-arrest due to STEMI, which could be left main versus multi-vessel. But unfortunately, there is no any sort of mechanical circulatory support available in our cath lab. This is the first shot with Jotkin left engaged in the left main coronary artery, showed only short stamp of left main without any distal flow. Then immediately engaged with XB 3.5 guiding catheter and workhorse wire 0.014 was secured in the ramus, but still there is no distal flow. Then I used the deflated balloon to 0/15, just advance it in and out to create any distal track to see what's distal to the lesion. And this is after daughtering of the balloon. There is, as we all see, there is diffusely diseased vessel LAD ramus left circumflex with distal left main bifurcational lesion. However, I would appreciate that the left circumflex ostium is relatively healthy. And then I decided to do a pre-dilatation with 2/15. Then 2 workhorse wires was secured in the left circumflex and the LAD, as we all see. Given that this patient hemodynamically unstable with cardiogenic shock and the ostium of left circumflex is relatively healthy, so the provisional stenting was our strategy. This is 3/28 Onyx drug-eluting stent was deployed at the LAO cranial view to cover the roof of the left main with a minimal protrusion in the aorta to secure the left main roof and extend to the ostium of the LAD. And this is after stenting. Then post dilatation using 3/15 NEC balloon was inflated in the left main. And this is stent post showed the difference between the diameter of the proximal LAD and the distal left main. Then again, post dilatation of LAD with the same balloon, 3/15 at 15 atmosphere. And then final bot using 3.5/15 and was inflated at 22 atmosphere. But unfortunately, at that time, the blood pressure of the patient started to drop. And as we all see, no reflow with the stain of all the descending aorta. At that time, unfortunately, the patient arrested. CPR was promptly started. Thankfully, after 2 cycles of CPR, the patient restored his circulation. And this is the final result. And then I took a last shot to the right coronary artery, showed right coronary artery diffusely diseased with a significant lesion in mid RCA. This is final shot, post and pre. So our take-home message: ST elevation myocardial infarction is involving left main coronary artery has been associated with significant morbidity and mortality. And unfortunately, most studies are limited because of small sample sizes. Many cases are never reported because of pre-hospital death. Again, provisional stenting is a relatively fast and safe technique, specifically in a left main PCI. Early utilization of mechanical circulatory support instead of increased doses of inotrope and vasopressor might avoid the downward spiral in patient with cardiogenic shock and resulting in a high mortality. Thank you very much.
Great case. So did you put the patient on ECMO?
No, this patient, unfortunately, there was no any mechanical circulatory support available at that time. He survived.
Patient survived.
Survived, yes, survived.
Wow. Amazing, amazing. I don't see a good myocardial blushing after you finish the case. Is there any myocardial blushing indicating good myocardial while you do contrast injection?
No, because yes, his blood pressure was significantly decreased. His blood pressure initially was unrecorded, but after finishing, it was around 70/40 on maximum support.
Okay, congratulations. We have 3 panelists: Dr. Kang, Dr. Amin, Dr. Yamamoto.
Yeah.
Do you have any questions?
Yeah. I don't see any balloon pump. Is it because you did not have the facilities to put in a balloon pump? Because that's one. The other thing is that you put a 3.0 stent in the left main, although you use a 3.5 NC balloon at high pressure. Do you think that is an adequate size for the left main as well?
Thank you for this question. Number one, there was no any sort of mechanical circulatory support available at that time, unfortunately. As regards to the second question, as you see, I do believe that left main was diffusely diseased because, but I cannot put more than 3.0 by 28 diameter, because even if you appreciate the last view when I did final bot with 3.5 at 22 atmosphere, the no reflow started and the patient arrested at that time. I was planned to do another session for RCA, and if I have IVAS at that time, I would appreciate if this stent is underdeployed or malapposition, I would give another bot later on. But because of this hemodynamically instability and no reflow, I prefer to go in this nominal case.
Dr. Shaheen, congratulations for your excellent result for this kind of horrible left main STEMI. In multi-center registry data with the Asian country, the left main STEMI, the mortality rate was 50%. Although the patient survived and visited hospital, the mortality was 50% in many databases. And I have a question that in this COVID-19 area, what is your protection strategy for the interventional cardiologist for this kind of STEMI patient?
Actually, we follow all the WHO protocol for personal protection, complete personal protection from face, mask, and shield, and everything else. But this patient was not COVID-19. He was negative, actually, but he was in the era of COVID-19. We did him CT chest, and it was free. But it was at that time it was a pandemic at that time, but he was completely free and negative for COVID.
Dr. Shaheen, how about you, the cases creatinine kinase of the maximum data?
Sorry?
The CPK, the maximum CPK.
CKMB, yeah.
CKMB, yes.
CKMP.
Yes.
I think I don't remember, but I was CKMB was 1,100.
Okay.
Sorry, high.
Yeah. Very horrible case.
Yeah.
Great procedure.
Thank you very much.
Okay.
Thank you very much. Thank you.
Thank you so much, Dr. Ahmed. And we have to move to the next case. I think Dr. Kim, would you like to introduce the second speaker?
Okay. The second speaker is Dr. Amin Ali from Interventional Cardiology Metro Hospital, India. His very interesting case, hairpin and reverse Guidewire technique for bifurcation stenting. Dr. Please.
Hello, everybody. Today, I am going to present an interesting case of bifurcation stenting, which I did by making a hairpin or reverse Guidewire technique. So before going to the video, I have no conflict of interest. And this is the brief history of this gentleman. He's a 64-year-old male who underwent coronary artery bypass grafting in 2014 by putting two grafts, one Lima to LAD and another left radial to OM2. He presented to us with chronic stable angina class 3. His ECG was unremarkable and echo was showing a hypokinesia of inferior lateral wall with ejection fraction of around 45%. He is a known case of type 2 diabetes mellitus, hypertension, and hypothyroidism, and was on optimal medical therapy. So we took this patient for coronary angiography, which showed proximal mid significant LAD stenosis with patent Lima to LAD graft. LCX was dominant artery, and OM2 was large branch, and it was showing ostial critical stenosis, and right coronary artery was non-dominant. This is the angiogram of the patient, which was showing in cranial view. There is a significant stenosis of the mid LAD with TIMI to distal flow. And in the aleocaudal view, we can see LCX is a dominant artery with there is a bifurcation stenosis of Medina 111 at the level of OM2. OM1 was a very small vessel. This is the right coronary artery, non-dominant diffusely disease. And this is the patent Lima to LAD graft with there is a competitive flow because of the patent. There was a native flow in the LAD. And this is the culprit artery. The left radial to the OM2 graft was completely occluded with. So we took this patient for coronary angioplasty of the LCX and OM2, and we have chosen for bifurcation strategy of two drug-eluting stent with mini crush technique. So I parked a normal workhorse wire in the distal LCX. Then I tried to cross the OM2 ostium, but it was very difficult to cross with the different guide wire, workhorse wire, and the polymer jacketed wire. So what I did, I make a hairpin loop of the Fielder FC wire with the help of a fine cross micro catheter, and I parked this hairpin into the OM3 branch. And while pulling back this wire, we can see it easily went into the OM2 ostium. So with the help of the hairpin or reverse guide wire technique, I was able to cross the OM2 ostium. So once I crossed the OM2 ostium, it was easy to manipulate the wire to park in the distal side branch. So after wiring both the branches, I did the serial pre-dilatation of the main vessel and the side branch. And after the pre-dilatation, I put two stents simultaneously, one in the side branch and another in the main vessel. The OM2, I put 2.5 into 15 drug-eluting stent, and then the LCX 2.75 into 33 drug-eluting stent. First, I inflated the side branch stent by keeping 2 to 3 mm struts into the main vessel. And after removing the wire and the balloon, I crushed the stent by inflating the main vessel stent. And after inflating the main vessel stent, I did the proximal optimization of the LCX stent. And after pot, I recrossed the side branch, which was easy to recross now by putting the stent, because now we have made the new carina. So it was easy to put a wire into the side branch, and I did the simultaneous kissing inflation with the non-compliant balloon. And then I did the final pot. And this is the final result, which was appreciated, which was good. TIMI 3 flow into the distal vessel. Although there was some haziness distal to the side branch stent, but because flow is TIMI 3 flow, so I stopped at that point. This is the cranial view, which was showing nice flow into the main vessel and the side branch, and there was no pinching of the OM3 branch. So for the discussion point of view, it was very difficult sometimes to do wiring in the obtusely angled vessel, and we can overcome this by either making a large band of the wire tip, which I tried in this case, but I'm not able to succeed. And we can use the microcatheter, dual lumen microcatheter, to cannulate the ostium, to wire the side branch, obtusely angled side branch. And another one is the reverse guide wire technique, which I used in our case. We can also use the deflection balloon, in which we can inflate a balloon in the distal to the ostium of the side branch, and then we can try to wire the side branch. This is how we can form a hairpin. Just insert a polymer jacketed wire through the introducer and then make a 180-degree bend. And after making the bend, we have to insert hairpin into the turn. So in conclusion, my take-home message is wiring of the obtusely angled vessel is very difficult in some situations, and reverse guide wire or hairpin guide wire technique can be successful in some cases, as in my case. And we have to respect all the steps of bifurcation stenting if we are going to do two-stent strategy. Thank you.
Thank you very much. Very nice case. Is there any question or a comment from panel?
Congratulations for your great case and very difficult reverse wiring. And in this kind of hairpin procedure, which is your preferred length of the hairpin, and which wire do you prefer for this kind of procedure?
For crossing the side branch, I prefer to use a polymer jacketed wire. In this case, I used Fielder FC wire with the help of a microcatheter to make the hairpin.
Okay.
Yes.
Dr. Ali, can I ask one question? And sometimes we must have using the double lumen catheter, because the only one catheter, one wire, you cannot go to the bended region or complex region inside the very far. And so we are always using the double lumen catheter, but you are using the only the single lumen catheter. How
Yes,
about the in this case go down to the region?
Actually, at that time, I am not having this case. I have done around 1 year back. So that time I was not having a dual lumen catheter in my shelf. So I use single lumen catheter for making the reverse guide wire.
Yeah. Is it good, or you feel difficulty to moving the wire into the distal lumen?
Surprisingly, it went smoothly in the first attempt only. It took few seconds for me to cross the lesion by using this reverse guide wire. Yeah.
Good.
Thank
Very
you.
nice. Thank you. Very nice case. Just wondering, because of the small OM branch, did you ever consider a drug-coated balloon to the branch rather than putting two stents for the bifurcation? What was your thoughts at that time, and why did you choose the two-stent strategy?
The ostium of the that OM2 branch was significantly diseased. Actually, it looks like more than 90% stenotic. So if I thought if I dilate with the drug-coated balloon, there are chances of the dissections will be there. So I went for the two-stent strategy directly.
Okay, thank you very much. Very excellent case. Move
Thank
to
you so
the second case. Dr. Santoso, with you.
I have the pleasure to introduce the next case entitled Optical Coherence Tomography Guided PCI following TAFI. to be presented by Dr. Tatsuya Kamon.
Thank you, Mr. and Mrs. Chairperson. I'm so glad to be here. I would like to present our case. I have no COI. This case is 84-year-old man. He presents dyspnea NYHS3 and was referred to our institution for the treatment of severe aortic stenosis. Past medical history, chronic kidney disease, EGFR 25. This is coronary angiography. There is a stenosis in LAD and LCX. FFR to LAD was 0.81 and LCX had small blood area. RCA also had stenosis region. We found this region significant stenosis. Our strategy was to perform TAVR for severe AS first and PCI for CAD with minimum contrast volume. We decided to perform PCI for RCA and to do careful watch-up in LCX and LAD with optical medical therapy. At first, he underwent successful TAVR without worsening kidney function. We used 60 ml contrast agent and no complication. Cardiac function was preserved and the progress after TAVR was good course. This is case summary. Staged PCI for RCA mid. PCI strategy, OCT-guided PCI with low molecular weight dextran without contrast agent. We aim to simplify the treatment in order to minimize the use of contrast agent. The system was radial artery approach and lock French sheath. Judkins Light 4 was used to engage the RCA and coronary guidewire was advanced to distal RCA. Guide extension catheter was inserted up to the proximal part of the RCA. Coronary artery imaging was performed using OCT with LMWD without the use of contrast agent. The stenosis region was mainly calcification with partial ulceration, and the calcification was mild in thickness. Predilatation with non-compliant balloon was performed. A Zotalurim eluting stent was deployed into RCA mid-region and expanded at high pressure with non-compliant balloon. Final OCT demonstrated good apposition and expansion of the stent and no vascular injury. This is final angiography. We performed successful PCI with only 15 contrast agent and without worsening renal function. There are two discussion points. First, which treatment should be preceded by TAVR or PCI? Second, should we use OCT or IVAS for patients with CKD? The prevalence of CAD in patients with severe AS is very high. The recent appropriate use criteria guidelines suggest that it is reasonable to offer revascularization before TAVR. Catheter engagement is more difficult with self-expanding valve than with balloon-expanding valves. In this study, there are no significant difference in terms of mid-term outcome among pre-TAVI PCI, concomitant PCI, and post-TAVI PCI group. So there is no clear answer to which treatment should be given first. In this case, the Sapien 3 valve was implanted 4 mm below the valve annulus, and the coronary artery height was 17. In this case, coronary engage was very easy. The relationship between the anatomy of the aortic valve complex and the implantation of the TAVR valve should be considered. Compared with IBUS, OCT feature higher spatial resolution, faster pullback, and better clear image. LMWD has been used for OCT image acquisition instead of contrast media. With regard to image quality, the prevalence of clear image segment was comparable between contrast media and LMWD. Furthermore, there is a good correlation between contrast agent and LMWD in terms of minimum lumen area, average lumen area, and average stent area. This study compared OCT-guided PCI using LMWD and IBUS-guided PCI. There was no significant change from baseline in the primary endpoint serum creatinine concentration. There are no significant in the volume of contrast medium, the incidence of contrast-induced nephropathy, and major adverse cardiovascular events. This is conclusion. That's all. Thank you for your kind attention.
Great case, congratulations. I completely agree with you that even though the result of IFUS and OCT might be the same, my personal bias is to use OCT, especially because we can measure exactly the length, the depth of the calcifications, and also the R. And we can measure the so-called calcium volume index. So if necessary, we can decide whether the patient needs atherectomy, like orbital atherectomy or rotational atherectomy. So we can decide on basis of OCT findings much better than IFUS. And secondly, sometimes we have to use a guideliner to assist us. But any questions from the panelists? Great case.
Yeah, it's a great case. I use OCT, but mine use a lot of contrast. So I think the picture that you showed with the low molecular dextran looks very good, actually. So I think this is definitely one of the things that you want to use in people with CKD. And I, as Dr. Teguh Santoso, I prefer OCT compared to IBUS. I think there's a lot more information that you can get. Great case.
Thank you for your good comment and question. We believe that there is an important implication in this case. As PCI will be more necessary patient with CKD comorbidity. In order to perform OCT with LMWD and minimize contrast, we believe it is important to use an extension, guided extension catheter, and simple of treatment, and patient with no heart failure. It's important.
My question is that when the heavy calcium in right coronary artery, do you perform first in TAVR or PCI? If you want to use some kind of orbital atherectomy or some kind of rota atherectomy, yeah.
OCT image found 400 micrometer thickness. So we don't use rotablator or diamond bag, and we use squaring balloon. OCT predilatation, after predilatation OCT, we found dissection calcification and can stenting.
Maybe you can check the CT with the calcification before you doing PCI or TAVI, and maybe if you have some very heavy calcification, maybe you must do the TAVI first. But if you have if you don't have the calcification, not so much, then I will do the, in my case, I will do the PCI before TAVI, because you should do the high frequency pacing at the moment of the TAVI.
Thank you for your good comment. heavy calcification, and we must use a rotablator. So we first perform TAVR and second PCI. But in Japan, TAVR is not approved for dialysis patient. So first we performed PCI and patient worsening renal function, and TAVI is not approved for dialysis. So this case, for this reason, our strategy was to preset TAVR followed by PCI treatment.
Okay.
I think we have to move. Excellent case. Thank you so much, Dr. Amon. Dr. Kim, would you like to introduce the next speaker?
Okay, next case is Dr. Hariom Tyagi from India. His title is his lecture title is primary angioplasty of left main with cardiogenic shock and pulmonary edema with IABP support.
Good afternoon, everybody. Can you hear me all?
Yes.
Yeah. Good afternoon. Today we are discussing this case, acute coronary syndrome with unstable vitals. So this was the. I don't have any financial interest, and we're discussing the case that 45-year-old gentleman, the known case of coronary artery disease, old anterior MI in 2011. It was stented in LAD and presented to us with severe retroesternal chest pain and dyspnea associated with sweating for last 2 to 3 hours. So patient was in CLIP class 4 with a cardiogenic shock and recurrent ventricular tachycardia. So his vitals at presentation, his blood pressure was 70 millimeter systolic, his saturation is 76, and he was not able to lying down on the bed. So after stabilizing with inotropic support and non-invasive ventilatory support, ECG was done. It showed the left Bunderwange block with diffuse STT changes, except in one AVL and AVR that there is ST elevation. Echocardiogram shows the severe LV systolic dysfunction with LV ejection fraction around 20% and severe mitral regurgitation with moderate TR and pulmonary artery hypertension. So this was his ECG at the time of presentation, shows the left Bunderwange block with the QS pattern in V1 to V3, diffuse ST depression except in one and AVL and AVR. So at this point, we have to discuss with the attendants the worst prognosis regarding the intervention, and the second option is the continuing the medical management. After stabilizing, we can take for the any angiogram or intervention. So after seeing the financial condition of the patient and the worst prognosis regarding the procedure, say the offer for the first option, that is the medical management, and then after stabilization, go for any intervention. So within, I think 5 to 10 minutes after this discussion, patient developed sudden cardiac arrest and ventricular tachycardia. So he was resuscitated with DC cardioversion and CPR. So after this resuscitation, patient was put on the mechanical ventilation and intubated with and associated with high inotropic support. And at this point, they changed their option, and they now want to save the life of the patient and ready to take any kind of risk and benefits. So they want to save the patient's life. So we discuss with the attendants further and take for the patient for the coronary angiogram. So this was his angiogram. It shows there is some minus restenosis in the previous stent, putting in the LAD, and the significant lesion, critical lesion in the left main from the starting from the ostial. And right coronary was more or less normal, some minimal plaque in the distal right coronary artery. So how we'll approach this case? Before starting the case, we have some accessories to be get ready because the blood pressure is not good. It is around 60 to 70 millimeter mercury even after the high inotropic support. And he was already intubated and on mechanical ventilatory supports, and shows in between some brady and tachyarrhythmia. So we put in this temporary pacemaker into the right ventricular apex, mechanical ventilation with this ventilatory support, and balloon pump was put. So this was the right coronary, this temporary pacemaker, but after putting the pacemaker, he developed some ventricular tachycardia. So we pull out this temporary pacemaker and keep into the inferior vena cava, just below the heart. And so this was the femoral axis was taken, and Judkins left 7 French guiding catheter was taken. So keeping this guiding catheter into the left coronary cusp just before the ostium, and trying to negotiate the wire into any vessel, whether it is LCX or LED. So we are successful to close the wire into the LED and LCX. So before going for further, that is, we have 2 options, whether we go directly for the stent, or we take any compliant or semi-compliant balloon before taking the stents. So we decided, because we need some optimization to cover properly to the ostium of the left main. So we first took the small balloon, semi-compliant balloon 2 into 10 millimeter, just keep inflate at the low pressure around 8 to 10 millimeter of mercury. So we took this 210 millimeter. So after dilatation of this small balloon, so there is a significant slow flow in the distal vessel, and at this moment patient again developed the ventricular tachycardia after the slow flow into the left system. So at this point this resuscitation was done, and tirofiban was given, and Necoran and anti also given in low dose. So after resuscitation, this was the scenario, and after that we took the stent 4 millimeter into 23 joints stent, and covering from the ostium and the restenotic portion in the left coronary artery, previously stented in 2011. So this was the 423 stent, just optimize the ostium, properly cover the ostium of the left main, and in the different positions, though this stent was inflated from the left main to LED. So this is after inflation. The flow was good in both LED and LCX. Then the 4 into 8 millimeter non-compliant balloon was taken to post-dilate this LED portion of the stent. And this is after post-dilatation with a 4 into 8 millimeter non-compliant balloon. Flow was good. In LCX, there is some plaque shifting, but it is TIMI3 flow. And after this, the proximal optimization into the left main, it was done with the 4.5 into 8 millimeter non-compliant balloon. So after post dilatation, this was the flow in LED, TIMI3 flow, and LCX also good. Patient was stable. So after the procedure, this temporary pacemaker was removed, and he was on high event this inotropic support, and this balloon pump was keep on this was the ECG after the procedure. So there is a significant change in the ECG. Blood pressure improved after the procedure, but it is also below 100 at that time on the mechanical circulatory support and the high inotropic support. So after the procedure, this temporary pacemaker was removed after the procedure, and at the same time, and this balloon was removed after 4th day, and gradually the inotropic support was reduced. The patient was remained stable during the hospital stay and discharged on the 6th day. So in conclusion, this is the show that the importance of the primary angioplasty of the left main in such critically ill patients. Thank you very much.
Thank you very much. It's a very great case, and very congratulations, successful PCI. Open for discussion, this case.
Nice case. I think you post-dilated the left main to a good size, but do you use imaging routinely just to make sure that your stent is well opposed to the left main vessel?
Yeah, we don't have any imaging facility in our center, but Keeping in the mind of the LAD and LCX vessel size, we keep that 4.5 millimeter non-compliant balloon at the high atmosphere around 15 to 16 millimeter of mercury. So it seems to be good, and there was no significant residual position of the stent in this boost.
You have any PCPS or ECMO at that moment? No?
Yeah, you don't have any this ECMO facility there, but because the patient was very poor, and I think this balloon pump was taken because the pressure is not maintaining even after the high inotropic support. So patient at that time of the procedure have only the 5,000 rupees in their pocket. So this case was done in the midnight around 12 o'clock. So they gave only the consent of this high risk consent regarding the worst prognosis of the patient. And all the financial consent was taken by the our managing department and by me only. So in this scenario,
okay,
so
and also you do the kissing balloon technique with the LMD? No.
Yeah, because it was the not significant disease previously in the left LCX at that time, and even after the procedure and high pressure dilatation of the 4.5 non-compliant balloon to the left main and 4 millimeter from left main to LAD, there is no significant this pinching of the LCX at that time. So we don't want to take another risk to compromise any further to the LCX. Okay, so we leave it like that only.
Did you check the IRIS after rectal stenting?
That I already mentioned, we don't have any imaging facilities in our center. Okay. But patient, this case was done around 2.5 years back, and he was in routine follow-up. Treadmill was done recently, 6 months back. He was doing good. He's on a single tablet with double antiplatelet therapy since then.
Okay, no question. Okay, thank you very much. Very congratulations, very successful PCI and very.
Yeah, thank you very much for your nice comments.
Thank you. Okay, move to next case.
Okay, nice to see everybody back. Sorry for the technical glitch earlier. So this is my case, managing complication of orbital atherectomy in calcified lesion. I'm Dr. Shargunan Das, and I did this case with my consultant, Dr. Kamraj. We are from Department of Cardiology, Hospital Serdang, Malaysia. So basically, our patient is a 60-year-old lady with comorbid dyslipidemia, hypothyroidism, right breast CA, for which there's no more recurrence after the surgery. And she had come to us March this year for non-STEMI. And the COROS at that point of time revealed 3-vessel disease. This is the vessel. So you can see that you can see here that the left circumflex proximally is diseased, and the LAD is also diseased proximally with heavy calcifications. So even this view, you can see the disease in the LAD. So the circumflex was the RCA was the culprit lesion at that point of time, and we proceeded to stent the RCA, whereby we inserted a DCB distally to the PLV, and proximally we stented with a Synergy 3048 stent. So we did a stage PCI to the LAD. When we brought the patient back for a PCI to LAD, we attempted to do a pre-PCI OCT. However, the OCT catheter could not be passed through the lesion, and further attempts to advance the catheter may cause perforation. So we stopped that, and we proceeded straight into, we decided to straight into to do the atherectomy. So when we did the orbital atherectomy, we did 3 runs at 180K RPM for each run, and we did a 2 polishing run. However, during the procedure, there was no chest pain. There was a transient bradycardia during the post-polishing period. However, it resolved with atropine. You can see the orbital atherectomy being done in this slide. However, immediately after the post-orbital atherectomy, we saw a large dissection with hematoma. So patients started complaining to have chest pain. There was ST changes noted in the hemodynamics panel. There was no bradycardia, and we made a very quick decision to prevent propagation of the dissection or even perforation. So we decided to stent the lesion immediately. So we stented the lesion with a 3030 drug-eluting stent, Resolute Onyx, and angiographically, it showed a very good result with TIMI-3 flow and no more residual dissection or hematoma. So this is the final shot after the stenting. And we post-dilated the lesion with the NC balloon 3015 and 3515 proximally up to 16 atmosphere. And this is the final result. There's no dissection, there's no hematoma, and a good TIMI-3 flow. So after that, we were able to do an OCT for this patient. A post-PCI OCT shows good opposition of the stent, and there's no hematoma, there is no residual dissection, there is no H dissections as well. So our learning point from this case is that how do we manage heavily calcified lesions, and what are the options do we have to what are the options we have for atherectomy, and how do you manage complications of orbital atherectomy and usage of imaging for lesion assessment and PCI optimization. So in the management of calcified lesion gives you large plaque burden and has a very greater degree of lesion complexity. And the nodules and microcalcifications are very much associated with higher plaque instability and vulnerability as well. So these are the a few options available for management of calcified lesions. So first of all, lesion preparation requires consists of intravascular imaging. We also have balloon-based techniques and calcium ablation techniques, and the calcium ablation techniques, we have rotational atherectomy, orbital atherectomy, and laser therapy. So we chose to do orbital atherectomy in this patient. So this is a very nice chart on how we manage heavily calcified lesions, and this can be summarized in this manner. So in our case, you see that the OCT was uncrossable, so we had to proceed straight into orbital atherectomy and thereafter for lesion preparation. So a few evidences are available on the imaging modality for assessment of calcified lesions, and you see that OCT ticks a lot of the boxes in terms of assessment of the accuracy of assessment of calcific lesions. Also, in the management of calcified lesions, we see that intravascular imaging, IVUS and OCT is able to identify high calcium load, and also OCT is more accurate than IVUS because it can define the calcium burden, the degree of the arch, amount of calcium, the thickness of the calcium, the length of the calcium, and it can also give you a three-dimensional volume of the calcium burden. So the above parameters predict stent expansion and response to balloon dilatation, which is why OCT is probably more accurate than IVUS. So in the usage of orbital atherectomy, basically orbital atherectomy has diamond chips front and back. So the calcium ablation is actually antegrade and retrograde. It does a two-way ablation of the calcium. Also, there's an elliptical rotation of the crown of the orbital atherectomy. And as the speed increases, the orbit of the diameter increases, and this crushes more calcium than the rotational atherectomy would. And a special centrifugal force is created, which causes a differential sending mechanism, an important differentiating mechanism compared to rotational atherectomy. So the advantages of orbital atherectomy is basically it can ablate in larger vessels up to 3.5 using the same crown as opposed to rotablation. It causes smaller size of the plaque debris, so there's lower incidence of slow flow or no reflow. Something that is also different from rotational atherectomy, and there is no, and because of this, there is no interruption of blood flow during the crown orbiting. There's no vessel heating, and there is differential sending. So these are the main important advantages of orbital atherectomy as opposed to rotational atherectomy. So in this patient, we also learned that dissection and hematoma are possible complications of orbital atherectomy, and acting on it quickly is very important. Other complications will include perforation, arrhythmia, and acute pulmonary edema, especially in patients with poor ejection fraction and ASRF. There's a lot of studies saying, giving us the evidences that the orbital atherectomy is actually safe and has a very good outcome. So just see them quickly. And this is the latest study that is ongoing, that is randomizing patient 1-to-1 either against orbital atherectomy or conventional balloon angioplasty, and the results expected in 2021. It will give us answer on the efficacy, further evidence on the efficacy of orbital atherectomy. So intravascular imaging post-PCI is another learning point, and the imaging is important because it can measure the size, apposition, and expansion, looks for residual dissection or hematoma, it looks for edge dissection, looks for tissue prolapse, it looks for geographical plaque miss as well. So these are the benefits of imaging post-PCI in OCT benefit post-PCI. So in conclusion, calcified lesions need adequate preparation. Orbital atherectomy is a safe calcium ablative procedure. Complications from orbital atherectomy can still occur. Quick and accurate decision needs to be made in managing complications, and intravascular imaging for lesion assessment and PCI optimization improves outcome. Thank you very much.
I'm informed that unfortunately we don't have time for discussion. Maybe we can entertain just one question. Any question from the panelists? Just one.
I mean, yeah. Nice case. I know you wanted to do imaging before the orbital atherectomy. I think the imaging would you have decided otherwise is use rotablator instead of orbital atherectomy if you had the images from your OCT before proceeding?
Yes. I think with the if we're able to pass down the OCT image, we probably might have had more information regarding the assessment of the calcium, the depth of the calcium, the arch of the calcium, the length of the calcium, and whether there's nodules, whether there are microcalcification, whether there's a pre-existing old dissections. In fact, also we would have been able to assess, and based on that, we would have made a better decision in choosing the right calcium ablative procedure. So I think a lot of information was not available, and that also contributed to the complication as well. Yeah.
So unfortunately we have to move. Thank you so much. Very interesting case. I'd like to ask Dr. Kim to introduce the last speaker.
Okay.
And give the final wrap up of the session.
Okay, thank you very much. Okay, the final presenter is Dr. Zhao-Hui from China. His present title is One Case of 3 CTO PCI with ECMO support. Dr. Liu, please.
Okay. Distinguished President and experts, I come from the 5th People's Hospital of Chengdu, China. And today I'm bringing a high-risk CTO PCI case with ECMO support. And the patient is 50 years old. 10 years ago, the angiography showing chronic occlusion, but which vessels were not clear. Left ventricular enlargement and the EF decreased significantly. ECG showed the Q-wave formation. Angiography was performed after cardiac function improvement. AID and AR6 were completely occluded. Only radius medianus was left, which proximal segment was severely narrow. RAD occluded segment is very long. RCX distal ratios are small. Remus medianus has some epicardial collateral ratios to LAD, RCX, and RCA. The blood supply range of RCA is large. The proximal of RCA was completed occluded. PCI risk is very high compared with PCI. CABG has many advantages, but the patient refused. LAD seems to have a stump, which can be confirmed by errors. The first and second collateral vessels are better. The condition of collateral to RCX and RCA are poor. RCA stump is short. The success rate of LAD was the highest. However, if LAD is successfully opened, there may be some septal collateral to RCA after 3 months. So we decided that LAD CTO preferred, followed by RCA and finally RCX. Compared with other CTO patients, this patient has a very high risk, and the biggest risk is circulatory collapse. When balloon or stent dilation is performed in Remus medianus, the whole cardiac blood flow is stopped. We have developed detailed risk control strategies. ECMO supply is very important and necessary. Adequate forward preparing is required. Withdraw the reverse system as soon as possible. ECMO implanted in the morning. After 2 mm balloon per dilation, severe vomiting soon occurred. Then the vomit was blown and stopped after a few minutes. Considering the unstable condition of the patient, we needed to deal with Remus medianus as soon as possible. 3 mm stent was implanted from Remus medianus to the distal left fasting in place, fasting release, fasting pump. As the balloon expanded, at this time, the risk of PCI has been significantly diffused. Use the field XT to find the LAD openings. The Guidewire entered successfully. XT moved on, little resistant. The Guidewire went on, but the courses were very tortuous. It's difficult to pass through here. XT successfully broken through the distal fiber cap. Multiple positional angiography found the Guidewire in the true lumen. .5 and 2.2 mm balloon successfully passed and redilated. Stent was implanted. Implanted 3.5 mm stent to the left main opening by Cunit technique. Guidewire removes maintenance intraballoon prostate dilation. Iris image show. Oh, sorry. Shows Guidewire goes through in the true lumen. .5 answer per lumen. The patient appeared woman again. I was worried about circulatory collapse, so I don't do the final kissing. Port with 4.5 millimeter balloon. This is the final reverse image. Everything and left image were good. This is the final review. After the second day, we saw ECMO. He was discharged after 1 week. The patient is a university teacher and is now working properly. The whole operation took 81 minutes. We think that ECMO is very helpful for very complex and high-risk PCI. We believe that it's very important to read the picture very carefully before the operation, to further plan, to identify possible risk, and to develop risk aversion strategies. I have requested for experts. Can I just handle remote maintenance and wait for a while to deal with the LAD CTO? But I'm worried about ECMO supply is still lead next time, and the cost will increase adversely. Thank you for listening.
Thank you very much. Very congratulations. Very top case success. Is there any question? You remain the right RCA CTO?
No. And the patient is not come back again. Okay. He is working.
Okay. Okay. Any question, comment?
You don't have using the mechanical ventilation? No. Only the ECMO. Dr. Yu?
Dr. Yu?
Yeah.
Okay.
Because this is a ECMO case, and maybe you have a frequent vomiting, so the maybe if you using the mechanical ventilation intubation, maybe the procedure will be safe, more safe, I think. What do you think?
Thanks.
The use of ECMO, I think a lot of us may not have the facility or the financial support to use ECMO, but I think it's a very nice case that you did with ECMO. I think we would love to do that sort of cases with this sort of support, but I think the issue of cost is one of the things.
Maybe I use IABP. Is that good than just use ECMO alone?
Okay.
Even if a successful PCI at intermediate disease, you must keep the optimal medical treatment for the heart failure. And after that, you would be able to treat another vessel. You can try after that.
Yes.
Okay.
Okay, if there are no questions, so congratulations, Dr. Yu. You're a very successful case, and keep maintaining the patient very safe. Okay, thank you very much, all the faculty member and case presenter to join this case presentation one. Okay, so be careful, resurgence of COVID-19. So see you next year. Bye bye. Have a good
Bye.
time.
Thank
Bye-bye.
you.
See you next.
See
Thank
you
you.
next year.